goes. I'm a breast cancer survivor, and 20 years out from my first time through it. And so I kind of have been through and felt most of these things we're talking about, as well as seeing hundreds of patients over the years. So we're going to talk specifically about some of the side effects of breast cancer treatment that are unique to breast cancer, the role of exercise, particularly in reducing our breast cancer recurrence, which is important, obviously, and what rehabilitation and exercise and TurningPoint can do for you. Just to kind of do kind of a definition of terms, an oncology rehab team could include physical medicine physicians specializing in oncology. We don't happen to have any in Atlanta, so that's probably why you haven't heard of any. There are a few around the country, but not many. Mayo Clinic, Sloan Kettering, and those kinds of big cancer centers often will have a physical medicine specialist, a doctor specializing in phys med, in oncology, but there's, again, very few. Could be PTs, OTs, dietitians, exercise folks, massage therapists, social workers, rehab, speech. These could be considered part of an oncology rehab team. And depending on the type of cancer, we may be more or less involved. So just to give you a little bit of an idea of TurningPoint, many of you may know us already, but if you don't, here's where we are and what we do. We're a nonprofit. And as a nonprofit, our whole mission is to improve the quality of women and men. We do see a few male patients each year with breast cancer by providing, promoting, and advocating specialized and evidence-based rehabilitation. And care is provided regardless of patients' ability to pay. And as a nonprofit, that's a big part of what we do and what we're about. So when our clinic's fully open, which it isn't right now, we are seeing some patients at TurningPoint, but definitely only a few due to the COVID-19 crisis. We do have a freestanding clinic. It's in Sandy Springs. And all we do is see breast cancer patients. So we're very specialized and really catering to the needs of breast cancer patients. And I apologize, I went ahead too soon. We have a financial assistance program that means that no patients are turned away. And a lot of our programs and services are reduced fee and complimentary. And Marilyn's going to talk a little bit about that at the end. That is all supported through donors, fundraising events like our Pink Affair, and that way we can offer financial assistance to patients either without insurance or where there's a big gap between what insurance will pay and the cost of providing the kind of specialized complex care we do. So that's how we sort of work. So the kinds of programs that we have include physical therapy, lymphedema education and surveillance. That's done by our physical therapists. This is a picture of one of our PTs, Lauren, doing exercise in our gym. We miss those days when we could do that, but we are hopeful to be back again soon, being able to use the whole clinic like that. We have exercise, both individual as well as classes, a Pilates class and a general exercise class each week. Now on our Facebook page. A lot of education events, kind of like tonight, but also about specific survivorship topics, not all just physical. We have education events related to nutrition and emotional side effects, dealing with children as you go through breast cancer, those kinds of things. Nutrition programs, massage therapy, support groups, and programs for patients with metastatic breast cancer. All of our programs are right now being offered via tele-rehab tonight, as well as we're doing tele-rehab with our individual patients, providing patient care in a format basically like this. And the obvious exception is massage therapy. We can't do that over a computer. We haven't figured that one out yet. So We also do a lot of promotion and advocating both locally and nationally. Whenever we get a chance to do a media event or run a course or sponsor an event, our whole goal is trying to get the care that we feel women and men going through breast cancer deserve and get it spread out. We can't see every breast cancer patient in the United States, so we do things like offering healthcare provider courses that we bring in people from across the United States. This is a speaker from Canada who's really well known in the exercise and cancer field. So we're always trying to spread the word and get care provided, again, ideally across Georgia, but also across the United States. So just a quick overview of the kinds of numbers we see. We've served about 5,000 patients, maybe a little more, since we started in 2003. Over about 700 women and men served each year. About 20% of our patients receive financial assistance to help them provide the care. As I said, we also have some complementary and reduced fee programs as well. And right now we're offering tele-rehab services during the COVID-19 crisis at no out-of-pocket charge to our patients. So that's a really big help to many of our patients who are struggling, going through both breast cancer as well as dealing with the whole pandemic. So let's move on to kind of the need and what we see as the need. I keep clicking to move my screen. Just give me 1 second to have a technical. I'm gonna go back. There we go. As we all know, probably tonight, I mean, everyone here, I think, is gone through this, and that's why you're with us. But during and after breast cancer, we have a lot of physical and emotional challenges, and these are common to almost everyone going through breast cancer. And the research shows that about 60 to 90% of cancer patients have impairments or issues, and the impairments could be pain, loss of motion, loss of function, fatigue. So 60 to 90% of patients have these things. They're amenable to rehabilitation. The research supports them, but unfortunately in the United States, most patients do not receive this care. And that's really unfortunate because we've known some of these things for a long time, that rehab can help, and unfortunately patients aren't referred. So there's some barriers have been identified in the literature, and we see these at TurningPoint all the time. We don't have good relationships between the oncology world and physical therapy rehabilitation. So the easiest way to sort of explain what I mean by that is the analogy of an orthopedic surgeon. We kind of grow up together when we're their fellowship and we're students, and they're used to referring their patients to us on a routine basis. And if you had knee surgery, you would expect to go and be referred to physical therapy after to get back your range and your strength and so on. But we don't see that happening in the oncology world, both breast cancer as well as all cancers, really. There's not really clear guidelines for rehab referral in sort of which patients need to go and which don't, and for what reasons, and lack of ability to specialized care. TurningPoint, as you probably have figured out, is the only kind of freestanding clinic that caters just to breast cancer patients, or cancer patients for that matter, in the Atlanta area and really in the Southeast. So we don't have a lot of places to send people. We also know from research and from our experience that women and men with advanced breast cancer, metastatic breast cancer, have even more limited resources. So that's a big issue there that we try to fill with some of our support groups and specialized programs for those patients. And so one of the things we say is that there's a lack of access to care for all patients, but if you add to that minorities, smaller centers, rural areas, lower socioeconomic groups, then it's even a bigger barrier to care. So we definitely also are working on ways of reaching out to different kinds of populations. Finally, lack of appropriate environments. Nobody really wants to go after they've had breast surgery and maybe reconstruction or not. Maybe they have hair or don't, and they don't really want to go into a big busy outpatient orthopedic gym to get back their range of motion. So we need appropriate environments for patients to go to where they feel safe and not embarrassed about how they may look or how they may feel. So that's an important part, and again, one of the barriers to care. The last part, they're kind of all together, we can kind of put these together, that misconceptions. A lot of patients that we see kind of expect that they're going to have have all these restrictions after going through their breast cancer, and don't necessarily feel that it's appropriate to complain about, hey, I can't use my shoulder, I can't play tennis again, I'm having trouble lifting my grandchild or my child. They don't want to complain because they feel like our doctors have saved our lives, which is true. But on the other hand, they're still not back to full function. And because they hesitate to advocate for themselves, it means that they're not getting the kind of care that they need. The last one is financial, and I put this last on purpose because often health insurance pays for these kinds of services, certainly for physical therapy. So we don't actually find financial is the biggest barrier. It's all those other things. So once it's not actually the financial piece. So let's go on to talk about some of the common physical challenges. These are ones faced by all cancer patients, and then we'll talk more specifically about breast cancer, the unique things that we go through. Fatigue, radiation-related issues, that chemotherapy, peripheral neuropathy that I mentioned, or CIPN, which is numbness and tingling related to chemotherapy, certain chemotherapies, and we'll talk more about that. And we know that excuse me, from recent research, we know that a lot of patients with CIPN have balance and increased fall risk. So that's an important new thing that we're looking at in the rehab world. Lymphedema is common to all cancer patients. Because it's so unique and special in the breast cancer world. I'm going to talk about that under the breast cancer piece, though. Just because of time, cardiac issues, respiratory issues, and osteoporosis are common side effects of treatment that we can't get into tonight, but could be a whole other talk. So let's talk about fatigue. Cancer-related fatigue, so we're talking about things common to all cancers, but definitely we see it in our breast cancer patients and in ourselves. It's often identified as one of the most distressing and common problems for people going through cancer, and has a significant impact on quality of life. There's been a lot of research done on fatigue and its impact. And in breast cancer, the research says 70 to 100% of patients report significant fatigue and significant reduced quality of life. And it's an issue that occurs during chemotherapy, but for many of us, it lingers on after. And in some patients, some research has shown that it can linger for several years after. So there's a lot of reasons for cancer-related fatigue, but it's generally considered multifactorial. It can be a direct effect of the cancer, but also many other causes that all work together to produce fatigue. And so some of it's the direct chemotherapy, but as you know, lots of patients have anemia going through cancer, depression and other kinds of issues can contribute. Stress, sleep, which can be a problem during and after chemo. So there's many causes of fatigue. It's not just sort of one thing, your chemo causes that. It's not a direct relationship. Many patients talk about it, and many of you may have experienced it. It can feel very unrelenting, just doesn't go away. You may have a nap in the afternoon and it doesn't go away. And it can feel kind of like walking underwater. All the time, no matter what you're doing. So it's a big issue, and it's an important issue. And a lot of us feel a little bit like if you have fatigue, you just kind of either need to accept it, but as it goes on, some patients start to feel like maybe there's something still wrong with me. Maybe my cancer's come back because I still have fatigue. So there's a lot of emotional impact of having cancer-related fatigue as well. So there is help for fatigue, and we at Turning Point we find that a lot of our patients are never, no one's ever talked to them about this until we see them. And the research is very clear. Study after study has shown that exercise, and by exercise it might be walking 2 or 3 times a week for 20 minutes to start with. It doesn't have to be running marathons, but aerobic exercise and strengthening, strength training reduces fatigue in patients during and after breast cancer treatment, and all cancers, in fact. So our approach with someone with fatigue would be to include exercise in their program and help someone get started with how do you begin when you feel fatigued. You don't feel like going out and exercising, so you kind of need a coach to do that, and that's where we come in. Resistance exercise, either with weights or bands. Working through with women on energy management, literally sitting and prioritizing what kinds of things you want to be able to do in a day and things that we may have to leave till later. Talking about sleep, pain and stress management, obviously referral or helping with managing depression if applicable, and nutrition. So all of that combined, it's often a team effort to help someone improve and get over cancer-related fatigue. So moving on to radiation-related issues. Again, we see lots of this in our breast cancer patients, but it does affect all cancer patients depending on if they have radiation as part of their treatment. If it's done like in our breast cancer patients over the chest wall, we can get pulmonary complications. Pneumonitis is kind of a temporary irritation of the lung tissue from radiation, but also long-term fibrosis, which can reduce our ability to exercise. So that's something we consider for patients with radiation. We can have some cardiac issues, but the big thing that we see is the tightness related to radiation in our patients in the chest wall area, armpit or axilla area, and the skin, fascia, and muscle can become tight. The radiation, as you know, is it's usually an inflammatory kind of response, but later the actual connective tissue can get tight, and so it doesn't stretch. That's a normal tissue response to radiation, but it can leave us with tightness and decreased mobility and function in our chest wall and upper extremity. Radiation also increases our risk of lymphedema because of the direct effect of radiation on lymph nodes. And other things like neuropathy, so issues related to weakness and numbness can happen in the long term because of radiation. And where we come in with the radiation piece is really changing up exercises and monitoring that cardiopulmonary system that could be affected. Soft tissue mobility and stretching, manual therapy to improve range of motion and decrease those effects of radiation. Obviously lymphedema, which we'll talk about in a few minutes. Intervention for neuropathy, that's an area where physical therapy, even outside of the cancer world, that's an area that we would be involved with, treating neuropathy and helping patients deal with that. And nutrition and speech pathology can come in, obviously, to the effects of radiation as well. So our last area that affects all cancer patients, and then we will get into the breast cancer, is CIPN, and I've mentioned it a couple of times, and basically it's a neuropathy that affects both hands and feet. It typically happens on both sides. If it's only on one side, we start thinking about other things. So it can include things like numbness and tingling, weakness, and it's basically nerve damage caused by certain chemotherapies. But in the breast cancer world, the chemo that's most common that we see used all the time as a first line is taxane, and that way Taxotere, Taxol. That's one of the chemotherapies that is known to cause the numbness and tingling in CIPN. It's dose dependent. In other words, as you go along through your chemotherapy, the CIPN can tend to get worse. It can actually have them postpone a treatment. so that, or decrease the dose so that as you get over it, so that you can get over it, sorry. And as I mentioned, because of the numbness and tingling in hands and feet, in the hands, we can have, see patients with difficulty doing things like doing small buttons up, that kind of thing. It can be a real problem. And then this issue that we're seeing with balance and risk of falling in patients with numbness and tingling and CIPN in their feet. So that's an area that, again, we're involved with related to exercise. Increasing the blood flow to the hands and feet may help it. Sensitization kinds of activities, balance training, if that's an appropriate thing. Even things like looking at footwear. If someone has decreased sensation in their feet, sometimes changing and adapting footwear and some things like that, gait aids if they need to, can help a lot. So it depends on the patient, but these are just some of the things that we may be involved in for someone with CIPN. So now what you've all been waiting for, because this is a breast cancer group, but all those other things do affect us all as well. So don't worry, I'm not going to go through the whole list, but there's just so many things that we go through as breast cancer patients. Surgery, the kind of surgery, how many nodes we've had removed, radiation, chemo, if we're on hormone-based therapy after our chemo and radiation are over. They can all contribute to some of the physical issues that we see in our breast cancer patients. And these are all really common kinds of things. The bottom piece, the lack of recovery advice, unfortunately, we still see patients that have been just given poor advice. Like, for example, be careful what you do because it might cause lymphedema. So they haven't really stretched out their arm and got their range of motion back, and they're not really sure what to do. So sometimes just the advice that they're given can actually increase the kinds of things we see during and after breast cancer treatment. So what we see mostly is in the trunk and upper extremity in our breast cancer patients. And I will use the term women because most of the people we see are women, of course, but women and men have very similar issues. Pain, reduced mobility and strength, axillary cording, which we'll talk about, decreased function, and arm and trunk lymphedema can all be issues. And it's not one of these. Most of our patients, and most of you may have experienced, they all come together, unfortunately. So just to give you a feel of these kinds of things, physical impairments, so upper extremity issues, and that could be range, pain, strength, etc. 66% of women undergoing axillary lymph node dissection have significant upper extremity issues. The second bullet point is some work that one of our colleagues, Katie Schmitz, did. And what they found, it was a group that she is out of Philadelphia, and it was a group in Australia as well. And they looked at women who have gone through breast cancer treatment 6 years after their treatment and found that 60% of women still had one or more moderate or severe physical issues related to their breast cancer treatment. And in bold, that were amenable to rehab. So they weren't being referred to rehab. They still had issues, and there's still things that can be addressed later. So that was, I think, kind of stunning, because it was only a few years ago and we're still seeing this, that the patients aren't getting to us to get this help. And then, as you know, lymphedema is an issue, and it's probably one of the most feared side effects of treatment. About 20 to 30% of patients develop lymphedema. So this is axillary cording. Many of you may have had this after your surgery. We typically see it in that fairly soon post-op, if we're going to see it. And at TurningPoint, I would say, and in the literature, probably 60 or 70% of our patients have axillary cording. And it's unique to breast cancer, and it can be very painful, especially in that early post-op period for 2-3 weeks post-op. And then it can continue to be painful, but also then often is very tight. It can limit our range of motion, limit our function because of the pain and the tightness. And a lot of women have it, and a lot of women unfortunately don't get it taken care of early on, and kind of end up with some kind of grumbling, reduced range of motion and function later on. This is a patient where we can see just a number of issues. She has axillary cording, but she also, that muscle in the front of your chest, the pectoral muscle, can get very tight. She's had radiation, and that added to the tightness. Tightness in her surgical incision, and when it's not mobile and isn't stretchable, that can actually add to just that feeling of tightness around your chest wall, and also shoulder range of motion limitation. So she's someone that we saw 8 months post-op, but we can do a lot of stretching, manual therapy, manual work with her, and then she ended up with full range of motion at the end. Of course, or I wouldn't have presented her, right? Activity limitation. So basically, limitations in function have, again, been well documented in the research, especially related to that upper extremity, decreased activities of daily living. So women report all sorts of things, again, right after their surgery and treatment, but also somewhat long-term as well, unfortunately. Things like difficulty throwing, stretching, doing certain things at work, that kind of thing. So we see that kind of lingering, and also reduced quality of life that tends to linger on as well. I'm not going into breast reconstruction options tonight because that could be an hour lecture in itself, but I think we all are aware that it doesn't really matter which breast reconstruction option you may have chosen or not, but if you have all of the options, well, they might result in great cosmetic results. They also present issues that us as physical therapists are dealing with. And so they can add to some of the limitations and restrictions after your surgery. I'm not suggesting that we shouldn't have them, but if you're going to put an implant under a pectoral muscle that needs to stretch, then often they need physical therapy intervention to try and stretch that out and make it more comfortable. And many of the tissue reconstructions where you're using tissue flaps like the latissimus, which is in this picture where we bring the latissimus, they bring the latissimus muscle and some skin from the back around to the front to make the press mound. That definitely has impact on core strength, so stomach and chest wall strength, upper body strength with your shoulder, because that's a shoulder moving muscle. So it definitely has impact there. And again, going back to my analogy of the orthopedic surgeon, if you had a rotator cuff repair, you would assume that you would be going to physical therapy after. In fact, most orthopedic surgeons wouldn't let you have it unless you were willing to go to physical therapy after. And if they forgot to send you, you'd probably ask for it. So we're seeing a lot of patients going through these kind of major surgeries that actually affect our muscles and joints and fascia just under the skin. And so it's important to have that opportunity to have rehabilitation to gain that range back and get that movement back. So there's lots of studies to support early upper limb range of motion exercise in patients. This happens to be one that I brought up because it's again, a colleague of ours, Margie McNeely, who's in Canada, in Alberta, and she looked at 24 studies. So it wasn't just one study, but so over 2,000 patients in this. And she basically looked at the evidence to support early limb or early range of motion exercise in breast cancer patients. And basically, all of the studies basically supported that early mobility is an important part of regaining their range of motion and strength. So I brought this one particular study to you because it's kind of, I think we know now that early range of motion is important, and it's been shown many, many times over. So the kinds of things that we would be doing in physical therapy and dealing with the upper extremity and trunk would be things like shoulder range of motion, ideally early post-op, as the previous slide showed. We might be doing manual therapy, soft tissue techniques, shoulder and arm and trunk strengthening. We spend a lot of time on the core area. Those abdominal muscles are often weak after surgery. Aerobic exercise, gradually helping patients to get back to a usual exercise program, and education regarding activities and function. So really working and coaching patients to get back to where they were, or even better than they were. So lymphedema, and I'm going to stop for just a second and put a light on because it's getting dark in the room I'm in, which I didn't account for, and I'm getting darker and darker. So here I am back again. So lymphedema, again, this isn't a full talk on lymphedema, but just some of the ways we look at it these days and some of the ways we screen for it and our approach at TurningPoint. This is our perometer. It measures arm volume for part of our screening program, as well as lymphedema management. As you know, it's a chronic progressive disorder, and it results from the impairment of lymph flow to the tissues, typically due to damage of the lymph system. And in breast cancer, that damage is done by removing armpit or axillary lymph nodes, and can also be added to by radiation, because it specifically does cause damage to the axillary lymph nodes, or lymph nodes under the site of the radiation. And it results in an accumulation of fluid, or a backup of lymph fluid in the space just under the skin. And as it builds, as it increases, then that results in visible swelling. So as the first bullet point says, it can be chronic. Once you have true lymphedema, unfortunately, it doesn't typically just go away. But the big thing is to try and, what our approach is to try and keep it at a very low level if you do have lymphedema. And it can be progressive. So again, part of our goal is to keep it from progressing. So the risk factors for lymphedema are very clear in the research. 20 years ago when we started, some of this wasn't known specifically, but the number of axillary lymph nodes removed are a risk factor. Obviously, the larger number of nodes removed, the more at risk we are. Radiation therapy. If we have radiation, we're at more risk, especially again if it's over those lymph nodes in our armpit. Body mass index over 25 is shown to be a risk factor. And then arm infection or injury can also be a trigger for lymphedema, because if you get an infection, it brings in fluid to that area as part of the healing process. And that fluid then may be just a trigger, kind of overloads the system, and can be sort of the onset of lymphedema. So that's something we do know from the research. There's lots of things that a lot of us still think of as risk factors, and that we hear from our patients that are told, oh, that might cause lymphedema. There's many things that aren't on this list, so we can talk about that after. Carrying a heavy bag isn't on this list. These are the known risk factors from many, many research studies. So our approach at TurningPoint, because we're evidence-based, we really talk to each individual patient about their risk of lymphedema. So one woman's risk of lymphedema with one node removed and no radiation is quite different than someone with 15 nodes removed and radiation. But even that person with more nodes and having radiation isn't necessarily going to get lymphedema. And so we really need to talk about that. Everyone has different risk levels, but it also doesn't mean you're going to get it. Some of the factors we may not be able to tell ahead, but there are some ways that we can reduce the impact of lymphedema if someone is going to go on to get it. Just really knowing the early signs and symptoms of lymphedema is important, because it facilitates early intervention. And that's a key. We found that with early treatment, we can keep it at a very low level and stop that progression. And with that in mind, we do baseline measures of upper extremity volume, ideally in our patients pre-op. Often we don't get them pre-op just because it's a tough time to get into to see a physical therapist at Turning Point when you're going through all that decision-making process. But if not early pre-op, then definitely post-op. Definitely talking about lifestyle advice. Exercising regularly is important. Shows that we know that it decreases our risk of lymphedema, as well as when people have lymphedema, it's something we actually use for treatment. And understanding potential triggers and being prepared so that a patient knows, yep, I know that I need to avoid these triggers, but if I do get a bit of swelling, we prepare them so that they know how to deal with it, when to call, when to get a sleeve on, that kind of thing. Again, this could be a full lecture, but I just wanted to mention hormone therapy, either tamoxifen or the aromatase inhibitors, create other side effects, physical and emotional, of their own. In tamoxifen, the one we deal with most in rehab, are hot flashes, because that can affect ability to sleep, ability to exercise, and so there is an important relationship. And all of these other things on this slide can also affect our whole quality of life and need to be addressed. And that might be a counselor, that might be just us in passing as we're working on someone's shoulder saying, hey, you might want to go back and see your doctor and check on some of these things. The aromatase inhibitors, the hormone therapy used for postmenopausal women can cause osteoporosis, joint pain, things like carpal tunnel and those kinds of things. And we actually treat that, those aspects and side effects at Turning Point like we would in more of an orthopedic or musculoskeletal population. So quickly, I think I've said exercise about 100 times, so I guess you know that it's important. It decreases our risk of breast cancer recurrence by up to 30%, reduces fatigue, decreases lymphedema risk, as we mentioned, and reduces lymphedema when patients have it, improves our range of motion, bone health, and it's an important part of our management of CIPN and those joint pain and joint issues related to aromatase inhibitor therapy. So the timing of rehab and exercise, and I've got my eye on the clock. I think we're good for just another couple of minutes and I'll pass it over. Basically, and I'm going to skip through that to kind of get to the end. And I'm happy to answer questions. But basically, the American Cancer Society a few years ago put together a task force that I was honored to be on, and we were looking at all of the research to support rehab for breast cancer. And we looked at specifically the physical issues and looked at all of the research involved and basically came to the conclusion that there was mounting evidence, and it continues to mount since then, that breast cancer rehab and exercise is effective in reducing many of the side effects that I've mentioned tonight. Developed a model of breast cancer rehabilitation that we use at Turning Point, which is, when possible, early pre-op assessment, and then seeing patients in that early post-op phase, and then ongoing surveillance so that we're catching some of these issues like fatigue or lymphedema at the very earliest time so that we can be most effective in management. And then at any point in time, as they're doing their ongoing surveillance through their different parts of treatment, chemotherapy, radiation, and so on, that referral to rehab would be built into that. At Turning Point, we don't necessarily send them away and have them come back. We teach them what to look for and when to come back. So they kind of just know to give us a call. So with that in mind, I'm going to turn it over to Marilyn. Stop sharing my screen. I'm talking out loud here. And then from there, Marilyn's going to take over. And I hope I'm going to chat while she gets her screen up. Please feel free again, as Aurelis said, to go into the chat. Do you want to go ahead, Aurelis?
We have one question. Can you explain again what CIPN is?
So I'll do it quickly while Marilyn's getting going. CIPN is chemotherapy-induced peripheral neuropathy. Sorry, it's long. And it's numbness and tingling that's in typically hands and or feet. It's usually both hands or both feet. And it is numbness and tingling, can even involve weakness, and it's related to chemotherapy, especially Taxol and Taxotere are two that tend to cause it, and they're common in breast cancer patients. Okay, Marilyn, over to you.
Let me unmute you.
I think
Okay.
you have to mute me, right? We're good? You can hear me? Okay. So now Jill's done an excellent job of showing us the big picture and the science behind that which you guys have all gone through. And so what I'd like to focus on now is directly what we're here for and what we can offer you. And during this period of COVID-19, we made the decision to offer all of our services without any out-of-pocket charge to our patients. So we feel like people with breast cancer are undergoing enough, and COVID-19 kind of extrapolated it logarithmically at a very high rate. So we're here to offer you any of our services with no out-of-pocket charge. And I'm going to go through a few of these services right now. The first being tele-rehab. And Jill has spoken about that a little bit, but we're extending those services to all of you there in Gwinnett County. We do an evaluation first. The evaluations, we were actually kind of surprised at how incredibly accurate they could be and how we could visualize things like that cording. You know, tightness was very easy to pick out. So we were really able to do a very accurate evaluation with tele-rehab. And from there, we screen our patients to either continue with tele-rehab for their exercises, or some of them might need hands-on therapy, like Jill was saying with the manual therapy. Maybe they have cording and we feel we need to use the laser to help with that. You know, the garment fitting, you could probably go with our recommendations, you could probably go and get one over the counter. But whatever it is you need, we're there for you, either through tele-rehab or clinic. Another thing that we offer is emotional support. We have a licensed clinical social worker that has been with us since the beginning. So offers support groups. And we have a little survey that we have on our website, and I'll show you how to get to that in just a minute. We have a little survey that if you would like to be part of a group, an emotional support group, then we just ask a few questions like, where are you in your journey? And what are your issues? So that we can appropriately pick an issue in a group. Our groups are max 10 to 12 women. So there's time for people to really bond within their group. Some of the other things we do are the physical activity, which is the little yellow piece of the puzzle here. And we have workout Wednesdays, and they're posted on Facebook every Wednesday, a new workout. And you can see the old ones too. And then we have what we call exercise snacks. So instead of being a food snack, it's a short exercise, 10-minute exercise ditty. So you don't have to take all your day with it. But if you just have a break to stop and breathe for a few minutes, an exercise snack. Keeping in touch is something we do with the patients that we've had. And we call up our past patients and just say, how are you doing? What's going on with you? Is there anything we can do to help? Nutrition is very important in this population of breast cancer survivors. You have different nutritional needs based upon the chemo and the radiation treatments that you've had. And this Friday. I hope I'm right, Aurelis. Is it Friday?
Yes, this Friday, May 8th.
At 11 o'clock, we have a nutritionist that has also been with us since the beginning of time, and she's incredible. And she's got a lot of energy. She's fun to listen to. And her name is Lisa, and she's going to talk on anti-inflammatory eating. She'll also talk a little bit about the new food label and how to read that. Education is an important part of what we offer. So like the nutrition thing, which is an educational session. And we'll be offering some things on walking as exercise, some stretches that can go along with that. That will be our June presentation. And in July, we'll have an educational event on emotional support. So we always want to make sure that we're meeting your needs. So if you have any specific educational needs, Lisa's going to be available for nutritional counseling one-on-one. So if that's something you feel that you need in order to be stronger throughout your journey, we can make sure that we arrange that for you. Oh, I guess I just kind of went through this. So here's a little picture of Lisa and her talk on Friday at 11. So here's, if you want more information, you can go to myturningpoint.org. And on the home page, if you go down to the bottom of the page, and it'll say blog and latest news. And then there'll be a statement that says pieces of the puzzle in compassionate care during COVID-19 crisis. And we're taking care of the whole person. So if you go to this web page, you can click on each of these different buttons and you'll see how to sign up for the nutrition thing or how to sign up for the emotional support groups and any of that. And also I believe Bobby is going to put an email blast that we had about all of these things and about the nutrition up on our website. Right, Bobby? Okay, I know she is. She mentioned that to me. So again, if you click on any of these, you can have more information.
Yes, Marilyn, I will.
Thank you, ma'am. So if you would like to get in touch with us, and if you have any rehab kind of needs, we would sure love to help you. You know, if there is enough of a need in Gwinnett County, you know, we may take considerations into renting some space, and because we're here for you, your needs. So let us know if there's anything we can do with tele-rehab. We'll work with you to get a prescription from your physician for such, and then you're going to be off and running. So that's kind of what I have. Are there any other Q&As that have popped up?
Yes. We have a couple more, either for you or Jill. One question is, does CIPN go away with time?
Jill, I'll let you take that.
There we are. Thanks. Good question. Generally speaking, it goes away with time. It can take months, and sometimes in some of our patients that have more severe CIPN, it can take even a year or two, but it gradually goes away. So if you have CIPN and you're a couple months out, it won't stay as severe as it is now. It goes away with time. We have had some really good results, as I mentioned when I was talking about rehab, and we don't cure CIPN, but we can definitely give people some exercise and some specific sensitization kinds of exercises. It's sort of a thing that actually we borrowed from the area of other orthopedic reasons for peripheral nerve damage, and it seems to be really effective in helping deal with some of those issues and maybe decrease the symptoms faster. So we're still working in that area. But generally speaking, yes, eventually it does go away, even in severe cases.
Okay. The other question you might have already answered, it has to do with CIPN, but how long does CIPN affect a person after treatment is over?
So I think that's probably the same answer, which is it can go away within a few weeks or months, but we have unfortunately seen some women where they're dealing with it for longer. And that may depend on the actual chemotherapy and the length of time you've been on chemo. And the place we sometimes see it where it's even a more significant issue is with women with metastatic breast cancer who are going through ongoing chemotherapy. It can be an issue. And again, there's a number of things that we can do to help with that.
Those are the last two questions that were on the chat.
Okay.
But if anybody has any questions, I'm just going to unmute everyone. Is that fine, Marilyn?
Perfect.
Sure.
Yep.
Okay. If anybody just wants to ask any questions, you're welcome to. This is our Q&A time.
It looks like Barbara's got a question on chat.
Oh, yes. Thank you. So 4.5 years, should she be concerned? I thought she thought that that's the way it would always be.
So 4.5, I assume, Barbara, I'm trying to see. Sorry, Barbara, I'm going, okay, wait. Barbara, 4.5 years, you've done treatment?
You can speak if you want. Okay.
I have not done treatment for the neuropathy. I just keep being told, well, it takes a long time. And it is decreasing, but you know, I still have tingling and a little numbness. It's my feet, my hands are okay.
To me, if it's something that's so minor that it doesn't affect what you're doing, yes, it will probably go away. If it's really affecting what you're doing, I feel like it's something that we should have a look at and see what we can do for. And again, we're not here to promote TurningPoint specifically, but
Right.
I think it's definitely worth having a look and seeing if between some exercise and some other things, and again, I don't mean just walking, but some really specific things we do with sort of the small joints and the small, just even some of the sensitization that we do. It's certainly worth a try. And the worst case is we would know in a few weeks whether it was helping or not. But that sort of goes back to that whole, we used to get told that about lots of things, including lymphedema, you know, well, unfortunately, this is just the way it is, and you'll have to deal with it. But now we know a lot more, like if we can treat it early and what we do to treat it. So I think it may end up being the same with something like CIPN. We're still working out what works, but I'm typically don't ever say, yeah, there's nothing we can do about it. I think it's worth a try.
Thank you.
Are there any other questions that we can help with?
Yes. Can you still get lymphedema after many years of chemo?
So great question. So chemo itself is not a risk factor. So I'm assuming you just meant after treatment, whoever asked the question. But the answer is yes. Most of I think that the statistic is sort of 80% of people that are going to get lymphedema, you get it within the first 3 years after your treatment. There are occasionally patients that get it many years later, but the bulk of people who are going to get it, it's 3 years. So yes, we have seen it occasionally. The research shows that 10 years out, you can still get lymphedema. We don't really know why at that point, because you would assume that you've pretty much had all the triggers, you're no different. And unless there's something very different, like you've gained a lot of weight, which may increase your risk, but you can get it many years later. But if you're someone that's concerned about it, it's typically those first 3 years. And then again, would depend on your risk factors. So never say never, but definitely that risk goes way down after the first few years.
So, Jill and Marilyn, could you guys, Marilyn, I know we sent a message to each other, but if you'll send me something on your Friday thing.
Oh, yeah. Carlos is going to do that tomorrow.
Okay, so I can put it up there, and please, Jill, anything that you guys have going on, if you will just post it on our Circle of Friends page.
Okay,
That would be great.
great.
Right.
We're
And I'm
happy.
going to send you too, Bobby, something you can post about the tele-rehab, because there might be a lot of people out there that just say, I don't know. Well.
Yeah, and I guess and I apologize. She recorded it, so we can put it back on our Circle of Friends page, so it can be replayed. So if there's any others that want to reach out to you, they can.
Sure, that'd be fine.
Yeah, because we have several new ladies that just have had surgery, so that would be great.
It'd be great if we could take care of them now and prevent anything.
Yes, absolutely. Well, thank you, ladies. This was awesome.
Thank you
Well,
so much for having us, Circle of Friends and Bobby.
Yeah,
Sure.
so I look forward to doing more with you guys.
Happy to do that. We're very happy that you're there for everybody, Bobby.
Well, I can't wait to bring you over here, Marilyn.
I know, we just need to find the volume of patients, and we're happy to do whatever's needed.
I will have a space for you. You have no fear.
Okay. Thank you, Diane,
Thank you,
for the little
Everybody
applause.
else stay safe. Thanks, guys.
Thank you.
Thank
Bye.
you.
Everyone. Bye.